Hey, Doc, how are you doing?
Good, Ryan. How are you?
Good. It's a great day. With the first episode of Brainstorm, I'm kind of excited. I
Very
figured you'd be a
exciting.
little excited, right?
Absolutely.
It's a great idea, by the way. But let's get into it, and then we'll start talking about why we actually wanted to do this, right?
I think we should first tell the audience who we are.
Yes. Just hold on a second. Let's just get the intro in here. So, like it says in the intro, this is Brainstorm. It's a podcast about the brain, about neurology and neuroscience. Yes?
Yes,
I'm Ryan O'Neill Williams, and you are.
I am Symeon Missios.
Excellent. You're not going to tell him all the other stuff. He's just saying he's Symeon Missios, but he should say I'm Dr. Symeon Missios. And
Well, I'm waiting for you to fully
to ask
introduce
you.
yourself.
Okay, so I'll ask you. So I'm Ryan O'Neill Williams, but I'm a local marketer here on Long Island. I love working with local businesses and local professionals, and of course, one of my finest clients is Dr. Symeon Missios, MD, FAANS. I'm trying not to forget all the letters. He's a fantastic neurosurgeon who is exceptional at what he does and provides exceptional healthcare. And I'm sorry, Doc, that's just something that's going to happen for me, because I kind of do promotion. Every time I talk about you, I want to talk about how good you are at what you do. So, why don't you tell us a little bit more about your background and how you got? Well, yes, your background and how you got here.
So thank you for the introduction, Ryan. So I'm a neurosurgeon, so I am a brain and spine surgeon. I live and work in Long Island, New York, and I work at Good Samaritan Hospital, which is on the South Shore, sort of in the middle of Long Island. And I work out of a group that is called Long Island Brain and Spine, and we're located very close to the hospital.
That's right.
And again, the goal of this podcast is to just have a conversation about topics in neuroscience that have piqued Ryan's interest, and hopefully the rest of you will find them interesting as well. So
Yeah, hope
this episode is going to be sort of a mishmash of different topics, sort of a neuroscience potpourri, if you will.
That's right. So we're going to talk about a few different things that were definitely in the news, but also someone actually did in the last few weeks and found themselves in the news themselves, posted all about. Well, and we'll get to that later on.
And I think
So,
we should also mention that anything that the audience would like us to discuss or comment upon, that would be a great way to generate more topics.
absolutely. We would like you to make some submissions if you'd like. At the bottom of this, you'll see it on YouTube, or you'll see this on Facebook. But wherever you do see it, please reach out. Have any questions for us? You want to talk about what is actually happening with you? If you have questions that Dr. Missios could answer, if you have questions about neck or spine pain, and most of the topics that you would find on his website, which is SymeonMissiosMD.com. And basically, if you have ailments or you have questions about treatments, this would be a great place to put them out. Of course, legally, I need to tell you that any advice that you receive here is as it's not binding advice. You should go to your doctor, see your doctor. Doc, you want to explain that to them a little bit more?
Yeah. So we're gonna talk about a lot of things, and some of what we're gonna talk about are opinions.
Yes.
and they cannot be taken for medical advice.
Yes.
If anything, the goal is to generate some interest that would, that would make you go to your doctor and have a further discussion about this.
Right. Right.
Um, but hopefully, the main goal is to generate that interest, um, and we hope that it will.
Exactly. So the kind of thing that Dr. Missios as a neurosurgeon works on is a brain tumor. So if you were thinking, oh my gosh, this is a neurosurgeon. Do I have a brain tumor or something like that? Literally, that's the first thing we're going to be talking about here. So take a look. This is
My,
an article that we saw, and this is kind of scary. This is like
how did you pick this? Where did you find this?
I told you I did this. I went to Google. This is what I do as a marketer, and I
Uh-huh.
know that if I told it, Google alerts, please send me some alerts about what is actually happening for neurosurgeon, what's happened recently in the news, and these pop up, and this was one of them that came up, and literally the word neurosurgeon triggered this to come to my email. And so, yeah, they're asking signs you have a brain tumor, according to a neurosurgeon. And you can see, and somebody fact checked it too. I thought that was interesting. Did you fact check it as a neurosurgeon? I'm just saying. But yeah, basically they're saying that there are different things that could possibly do that. Now, this is scary. Just saying headaches and when to seek medical attention. Doc, is it just a regular headache? What would bring it so that you have a headache and you're like, oh my gosh, I might have a brain tumor?
Yeah. So, I mean, gosh, everyone gets headaches. Some people on a daily basis, and brain tumor is the last thing that comes to your mind, and it's a very scary topic. Um, but certainly there are some signs and features that would make you at least seek medical attention. And nowadays it is so easy to get any cranial imaging, a head CT or an MRI. It's so widespread and becoming more affordable, um, that that's the easiest way to figure out whether there is a brain tumor there or not. But certainly some of the brain tumors can manifest in multiple ways. Headaches that are not getting better certainly is one of them. And what should cause concern are headaches for someone who doesn't normally get headaches. If someone
Oh,
has migraine headaches on a daily basis, and that pattern doesn't change, then less to worry about. But if the pattern changes, then
right.
certainly something to worry about.
Yeah.
Definitely headaches that are accompanied by other issues as well. So, and that can be numbness in one of the extremities, in the arm or the leg,
Right.
weakness, so difficulty moving the arm or the leg, or walking, or trouble with balance, things like trouble with speech or trouble with vision, mainly peripheral vision.
Right.
All those are issues to make you seek medical attention and probably get a head CT or an MRI to be safe.
Oofa. Yeah. So if you're having persistent headache, right? And what about, yeah, and you're saying persistent and someone who doesn't get headaches a lot, but all of a sudden they're getting them and they're keep on going for days or whatever. Yeah. So listen, we've spoken
We
about this. Mhm.
No, we say that headaches that are progressive, meaning
Oh,
that
okay.
they keep getting worse and they
Worse.
keep getting more frequent.
Okay, yeah, that would be a thing. So technically, that is kind of what happened to this young man, who it was a client of yours, and you got a nice write up. And
Patient, Ryan, not client.
I think of my people as clients. I take care of you. It's the same thing, right? I guess you the way you present it is, I'd like to take care of people just like my family. We had this whole conversation before, about how Doc wants to make people feel like their family when they show up in their office. But yeah, this gentleman basically had an intervention because he was having a few different symptoms, right? Exactly. Was that one of them? Headaches was one of the symptoms he was having?
Yeah, but the other thing that brain tumors can cause are seizures.
Mm-hmm.
And a seizure, everybody, most people know what a seizure is just from media and watching it in different movies.
Right.
Uh, but a seizure involves the firing of multiple neurons in a very synchronous fashion.
Yeah.
It may sound counterintuitive, but your brain is composed of billions and billions of neurons, but they're all firing at different rates and at different times.
Okay.
So there's sort of like a chaotic pattern of
Right.
firing.
Right.
If a lot of them start firing at the same time, then we call that in a synchronous fashion.
Right.
That can be bad for the brain, and it causes the normal function of the brain to temporarily stop, and it leads to a seizure, which involves the loss of consciousness and the rhythmic, tonic clonic, as we refer to, the rhythmic activity of muscles, which causes the shaking.
Right. So
So
everything
anything,
turns on at once.
everything turns on at once,
Yeah.
yes. And there's no voluntary, no conscious control of it.
Right. Right. It's
Uh,
like in those movies when like aliens come to your house and they turn on every one of your appliances. Everything starts blaring and turning on and off and on and off because there's no true control. It's just forcing everything on all at once.
which movie is that?
I'm just you've seen enough alien movies where let's pick one. We don't want to get in trouble, but of the third kind, of the
Oh yeah, yeah, yeah. Okay, all right, all right. You're
like
dating
that. But
yourself.
yeah, if you think of, or even a good episode of the show with Sculler and
X-Files.
yeah, X Files, perfect, like one of those. I
We're
mean,
allowed. We're allowed to say X-Files, right?
yeah, we could say X Files. It's double
I
check.
love that show.
That's a great show. It's so funny. Sometimes I think about what it is that we do have in common, and that's one of the things, like sci-fi and movies and blah blah blah.
But no, this patient presented with seizures, and it was he's a young patient. He had a
Yeah.
seizure, and that's what led him to the hospital. And
Mhm.
what happens is a seizure after a what happens after a seizure um, is that patients can be very sleepy,
Mhm.
and they can have some residual weakness or trouble speaking that can last for several hours after the seizure has stopped.
Wow.
So a lot of times patients after a seizure, they end up in the hospital where we do a head CT to start and then an MRI of the brain. And in this case, a brain tumor was identified.
Okay.
Um, and the brain tumor involved an area of the brain that affected sensation.
Okay.
So the right side of the brain controls the left side of the body and vice versa. So because that area of the brain was irritated, the patient experienced numbness, tingling on the opposite side of
Oh.
where the tumor was.
Oh. Okay.
Um, and the patient ended up being diagnosed with a tumor in that location and ended up having surgery to remove it. Thankfully, it was in a location that was safe to remove it.
Yeah.
And that's not always the case, depending
No.
on where it is in the brain.
Right.
And eventually, the patient did very well.
Yeah. He literally says at the bottom. He says basically, now I feel fine. I mean, I feel perfectly normal. He actually said that at the end. What kind of tumor was it?
This was a type of tumor that we call it a glioma.
Mm-hmm.
And what that means is a tumor that starts in the brain from the brain itself.
Right.
Um, and the brain consists of two main kind of cells. One are the nerve cells, which obviously they're the ones that fire, and they are the electrical wiring of the brain.
Yeah.
Um, but they need a substance to that supports them. And what does that are there's two groups of cells that offer that support: the astrocytes and the oligodendrocytes. And these tumors originate from these supporting cells.
Okay.
The neurons themselves, they don't do much dividing, so they don't tend to form, for the most part, tumors themselves. But the supporting cells, they do a lot of dividing, and unfortunately sometimes they can create these tumors.
Okay, cool. So, ladies and gentlemen, if you want to read more about what actually happened to this young man, Dr. Missios' patient, you can actually go see it on SymeonMissiosMD.com. That's SYN. Just like his name's spelled right here. Symeon Missios. Just take the comma out and put .com at the end, and you can check that out. So, did you use any robots to work on this gentleman's brain, or was it more like you physically went in there? Because apparently they're saying there are places that added robots in February, and they were specifically for neurosurgical robots.
So how did this pique your interest? How did you pick?
Again, listen, if somebody could get rid of you, I'm not happy about that. I want you. I don't. Robots are never going to come to me for marketing. Robots are like, I will do it myself and get it done. they'll connect into YouTube or Yahoo and Google and Facebook and do their own thing. So I was like, no. In general, yeah, that's fantastic sci-fi kind of stuff. I mean, can you imagine if robots are actually used? But I would assume that they're programmable robots. Like we're not to the point where
Yeah, we're
it,
we're not at
yeah,
the point, right? We're not at the point where
yeah,
a surgeon can be replaced by a
by an
machine
yeah, like an
yet.
android. Yeah, it's
Yeah.
not Lieutenant Data doing neurosurgery yet.
Um, you know, I think probably it's not going to be in our lifetime, but in the future, who knows, right?
Yeah,
Um, but yeah, robots are used in the healthcare field, and especially in surgery. Um, and over the past 15, 20 years, more and more frequently. Um, when it comes to neuroscience, there are machines that can help us, uh, and mostly with the accuracy of what we do. They can help improve the accuracy. Uh,
are you
there
talking about
is
neuro navigation? Is that what you're
Neuronavigation is a machine that we frequently use in surgeries. I wouldn't call it don't think of it like a
robot?
robot, like
Yeah, yeah, exactly.
again, like Lu- Commander Data coming to the OR and giving you a hand, although that would be very, very cool. uh this
Just not
is
yet. Not happened yet.
not yet. This
Mhm.
is more like a computer station with monitors and a special camera.
Okay.
And the patient has an MRI before the surgery,
Right.
and then during, it's a special MRI that is very high resolution, so that when you put all the MRI stacks, all the MRI slices on top of each other,
Okay.
you can actually have a 3D recreation of the patient's head and face and
Oh.
brain.
Oh, okay.
So the machine takes that into account,
Right.
and then when the before the surgery starts, the camera, there's a special camera that reads the facial features of the patient and matches them with the MRI.
Oh.
So then you have special instruments that this machine can recognize. They look like fancy pointers, if you
Yeah.
will,
Okay.
and you can touch them on the patient's head, and on the monitors you can see the MRI, and essentially you can touch the patient's scalp and see what part of the brain is under where you're touching.
Okay, so what you're talking about is almost like a 3D rendering that's sort of translucent to a point where you can actually see almost everything through the layers, and like everything is different colored and that sort of thing.
Yeah, you don't. It's still a 2D representation because you're
Mhm.
still watching it on a monitor.
Oh, okay. So
You don't get like a 3D projection like you would with
no.
augmented reality, for example. Although people are looking into that,
Into that exactly.
um, but it's still a 2D representation. But it helps you a lot because you know exactly where to make an incision, and you can tell the limits of where the tumor is, and it allows you essentially to do the surgery, yeah, more in a more effective and safer fashion.
Right. So how is that the same as a robot? I mean, are they saying that that's a robot? No, that's just a different look. Because I'm assuming a robot is something that you would tell, okay, you can do 3 or 4 moves before I touch you again, and then you do, these 3 things. Like it's basically going to be programmed to look and see what's happening, and then make certain incisions or do whatever because it's a fixed thing. Because
Yeah,
from a human perspective, I mean, things have to change, and as they change, you would make the adjustment as a human, but a robot would not be able to do that. I would.
yeah.
Yeah.
The that can happen,
Hmm.
and there are two settings where the robot it takes a bit of a more active role. But you got to remember, you're dealing with a human patient, so uh, the extent of independence that these machines have has to be limited and under very tight control.
Sure.
Um, there is a surgical procedure that involves implanting uh, very thin, very flexible, essentially wires into the brain, and we call those electrodes. And you do that in order to record different areas of the brain, to record the electrical activity. It sounds a little crazy, but that's a very good way to pinpoint where seizures are coming from.
Great.
So again, as we said, seizures involve an area that generates abnormal electrical activity. And sometimes it is really hard to find that area.
Yeah.
And a procedure that can help is implanting these electrodes in different areas of the brain, um, and just get some recordings over the next few days.
Okay.
So these where these electrodes go in and how they are implanted, it takes a lot of planning because you don't want to put them in the wrong
Wrong
spot that
play,
would
of course
cause harm.
not.
So there is a robot that helps you implant these electrodes. You do all the planning ahead of time,
Right.
and essentially that robot will, it looks like an arm, like a mechanical arm,
Ooh.
and it just sort of travels around the patient's head and pinpoints where to make the hole in the skull and the trajectory of how to implant the electrode to make sure that it ends up in the right spot.
Ah.
So that's one use of robots in neurosurgery. The other one, it's a similar concept, but a lot of times for spine surgery, you end up putting screws in when you do a procedure called a fusion,
Okay.
typically in patients' upper or lower back.
Right.
And most of the times, surgeons place those screws based on anatomical landmarks. But now there are robots being developed that again they're able to read the patient's anatomy and bony features. And again, it looks like an arm that moves and gives you the right trajectory so that you can place your screw and you can be certain that it goes in the right spot. So,
So what do you mean by anatomical landmarks? You got to explain that a little bit for the layman.
so one of the things that you learn in during our training is sort of what different parts of the spine look like.
Mm-hmm.
And these hardware, these screws in this case, they have to be in certain areas to provide the mechanical stability that is required, but also to make sure that it's safe and that the screws will not hit any nerves that are in the way, for
Okay.
example.
Okay.
So to now, if you think of the spine, it's not free floating. You can look at a spine model and say, yes, that's easy to do. But in real life, the spine is completely surrounded by muscle, and
Oh.
you only get a limited exposure of the bones. So you kind of have to go back to your anatomy and anticipate what you're going to see in order to find the proper entryways to place your hardware.
So often when you're doing a spine surgery, you're telling me in order to get to the bone and to do whatever it has to be, you have to do, say, for able to figure somehow way to make the bones actually come back together. You're going to have to lift that muscle off and then put it back sometimes. Yes.
Oh, 100%.
Okay.
Yes. There is no way to get to the bones without going through the layers,
Yeah.
which are skin and fat and muscle.
Yeah.
And unfortunately, that's where a lot of the post-operative pain comes from.
Yeah. That would make sense.
And in general, again, it's not a rule or medical advice, but in general, the more muscular someone is, they can run into more pain because you have to
Wow.
do more dissection.
Yeah. And then they're also going to they have to repair more tissue.
Right. Yeah. And now a common question is, well, how do you put the muscle back together?
Yeah. Well,
Um,
it knits itself back together, right? Isn't that what it would do? Yeah. But you
yes,
you try to do as much as you possibly
you
could.
try to do as much as
But
you possibly
yeah, but
can.
they're gonna have scar tissue in there,
Scar
and
tissue
yeah,
is like super glue.
yeah, okay,
It's eventually it will form in between the muscles
okay.
and help glue, if you will, the tissues back together.
Wow. Will ever is anybody who has that surgery like ever go back to what they are? Is that super glue enough to give someone back their full mobility? I mean,
Yeah, I mean, it depends. Um, a lot of people do.
okay,
And we have scar tissue in our bodies, just from growing up.
yeah,
So it depends on the extent of surgery, and it depends on their previous level of how well conditioned they are, how healthy they are.
yeah.
Um, but yeah, it depends. But a lot of people do. Yeah.
Yeah, I hadn't even thought of that. That yes, it's depends on how well they and that the fact that we have scar tissue simply from growing up because our bodies are stretching and getting larger. That's fantastic. All right, so I mean that's the way you think of it. What's weird is we're talking about this, but as we're closing up and coming closer to the end of this particular show, uh, that cool thing that you were talking about, what is it? The Starlink? No, it's not Starlink. The one that
N-
Elon Musk is working about. We're not going to talk about
Neuralink.
it. We're going to talk about it next episode.
Neuralink.
Neuralink for next episode, which is basically the new way that our brains are going to interact with computers by having the same fibers that you were talking about that the robot could possibly put into your brain in order to connect with a computer, which is fantastic. And we're not going to talk about this week, but it will be great to talk about next
Okay.
week. But yeah, we're closing up. Doc, if you have anything else, is something specific you want to tell everybody out there, we could do that. But we're almost out of time.
No, I think we should welcome any topics that the audience would like to hear.
It'll be great.
Otherwise, it's just going to be Ryan picking them for you guys. So if you want to spare yourself the pain, please send us topics we can talk about.
That's right.
They have to be neuroscience related,
Really,
and please no politics.
Oh yeah, we're trying to stay away from all that, right?
We don't want to get sued. So
yeah, we're trying to stay away from politics, and we're trying to stay away from the pandemic, all of that we're trying to stay away from, because yeah, that's when they take your thing down. But yeah, Doc, it's great to talk to you, man. We'll do this again in about a week. And ladies and gentlemen, I want to tell you again, this is information that you're probably going to be able to find on the homepage of Dr. Symeon Missios. This is his website. We're excited about it. It's brand new, and we'd love it for you to come over, take a look at it, and say hello to the doc. And of course, submit your questions for the next time that we have Brainstorm. Okay, Doc, I'll see you next week.
All right. So from your friendly neighborhood brain surgeon. All right.
Sound like Spider-Man. Okay. Yeah, and I'm Ryan Williams, your local marketer, and your geek nerd who sees sci-fi and everything. All right, guys, you take care, and we'll talk to you.
You can't send him Star Trek questions.
You can, but they have to be related to neuroscience and neurosurgery.
But you can write the questions in Klingon language.
I actually can't read Klingon. I think the only word I know in Klingon is kapla, which means success.
Hello.
Yeah.
Okay.
Now we just screwed up the whole show. Now we can't post this nowhere. You're like, oh, that's Star Trek geek. There's no possible way this show can be good. Nah, it's great. It's great. And I really am happy to do this with you. Let's talk about some new topics, especially the Neuralink, which I am excited.
Are we done recording?
Oh, he says, "Are we not recording?" No, we're still recording. We're still going. We broke through the third wall. It's gonna happen. But yeah, I want to talk about that next week. All right. So, Doc, it was good to talk to you. We'll speak soon. All right.
Take care.
All right. Bye-bye.